Flap-based LASIK has been a popular and successful procedure for many years, with millions of eyes having undergone LASIK, yet occasionally we come across complications such as micro or macro striae with or without epithelial ingrowth, seen in the early or late post-operative period, which are often associated with trauma or eye rubbing. Occasionally, striae can produce significant visual discomfort, especially when involving the visual axis. I would like to share a few cases where we have used different techniques of managing flap striae in our hospital, depending upon the type and severity of the striae and the post-operative time it was detected. In early post-operative period, these complications are relatively easier to manage. In the first case, the patient underwent contour femto LASIK and his post-op vision was 6/6 with both eyes. He came 3 days later with history of trauma and blurring of vision. Vision in left eye was 6/18 and on slit lamp examination, early flap striae was seen, which was confirmed on OCT. We managed the case by lifting the flap and clearing the epithelium from the flap edge and the stromal bed using a patent spatula. This is essential to prevent possible epithelial regrowth. We repositioned the flap and gently but firmly stretched the flap on the epithelial surface, pushing the edges away from the central cornea. This allows the flap to fill in the ablated stromal bed. We then debrided the epithelium overlying the striae. While some surgeons believe that in early post-operative period, epithelium removal is not necessary, but in our experience we found that it helps to remove the epithelium because even in the 24 hours the epithelium remodeling over the striae is sufficient to prevent the flap from getting repositioned completely. Using the flap double twist technique, flap is carefully twisted obliquely and sequentially in 2 opposite directions while applying gentle pressure on the flap in order to completely dehydrate the flap and the stromal bed. The patient did fine with 6/6 vision. This patient who underwent LASIK surgery presented with history of blunt trauma to the left eye 1 week back and complained of blurring of vision. On examination, we found flap striae with epithelial ingrowth which was not involving the visual axis. We planned for left eye flap wash with the help of intraoperative OCT. Flap was then raised and the epithelium cleaned from the stromal bed and the edge of the flap with the help of patent spatula. AIOCT used intraoperatively is a new tool to manage post-LASIK complications since we can see the extent of flap striae and epithelial ingrowth and treat accordingly. It further helps to manage the case on table, like how far to lift the flap, see the flap apposition at the end of the surgery, and also the surgical results. Our next patient presented with history of old trauma and complained of severe loss of vision. On examination, there were microstriae with fibrotic epithelial ingrowth. Extent of growth was confirmed on OCT, so we had to lift up the whole flap, wash the pocket of white fluid, and clean the bed and interface with patent spatula. But since the scarring was very dense, diamond burr was used to remove some of the epithelial ingrowths from the interface and the bed. The video has been made short to focus on important steps, but the whole procedure took about 20 to 30 minutes time. Intraoperatively, mitomycin C was applied on the stromal bed and flap underside, where possibility of recurrence was highest. It is surgeon's prerogative to use mitomycin C in patients who may demand so, like in long-standing or persistent striae. Patient gained 6/12 vision post-operatively and went on to do well. My next case is post-LASIK patient who had history of trauma and on slit lamp examination, vertical flap striae was seen on retroillumination through a dilated pupil, which was confirmed as negative staining of tear films on fluorescein stain. Since the striae was involving the visual axis, we decided to remove the epithelium first. We carefully dissected the corneal flap along the edges and cleaned up the epithelium from the bed and the interface. We then stained the stromal bed and the interface with fluorescent stain. Flap striae is best seen by a negative staining with fluorescent at the apices of the striae and pooling in the trough. I would like to show an interesting case when we first started doing smile surgery in our hospital, where we were asked to do a few cases of flex. This was a learning case for all of us. As compared to smile, flex requires a much bigger side cut, which probably exposed the patient to a high risk of complications. As the hinge was inferior, so the lid movements played a role in such cases. We managed the case by lifting up the cap, which was 50% of the cap made. We were able to remove it adequately. This was confirmed by negative staining with fluorescent stain. To conclude, I have shown various situations and different techniques used in the management of LASIK flaps dry, and whatever works best in surgeon's hand can be his personal preference. Early recognition and treatment is associated with better visual outcome and reduced risk of developing fixed folds. Thank you.